Your Highness the Father Emir, Your Highness Sheikh Amoza, Royal Highnesses, Ministers, Ambassadors, and ladies and gentlemen, I am truly honored and privileged to be able to speak to you today. This is an extraordinary forum, and it's a great honor for my organization, the International Rescue Committee, to be able to advance some ideas to you today. If I might, I want to pay a particular tribute to my friend, Professor Lord Darzi. I think we're all here in one way or another because of you, Ara, and your work in the UK as a government minister was extraordinary, but now your global influence is a real wonder, and I really feel proud to be able to call you a friend on this occasion today. The words that you used about creativity, about innovation, and about partnership go to the heart of the argument that I want to make to you today. The argument is this, that we are meeting at a time of extraordinary innovation in healthcare for those who can afford it, but unspeakable human suffering for those left behind. And none are as left behind as those trapped in war and conflict. So one of the major themes of the conference, healthcare in conflict settings, could hardly be more timely. My focus today is on the most vulnerable in that group, because none are more at risk than young children, too many of whom are dying of preventable causes in fragile conflicts. I want to talk to you today not just about what ails them, but about what we can do to save literally millions of lives. The International Rescue Committee was founded in the 1930s by Albert Einstein to support refugees fleeing persecution and violence arising during World War II. Today, we work in over 40 countries supporting people whose lives have been shattered by conflict or persecution, and we help them rebuild their lives. As Michel Hussein just reminded us, with 68.5 million people displaced by conflict and persecution around the world today, we are, unfortunately, a growth industry. We partner with a range of organizations and governments, including the Education Above All Foundation from here in Qatar. And what we see every day in the countries that we work in the communities that we work with, are three important things, three challenges in the world today. First, states that have been shattered by violence, conflict, and fragility are falling further behind, much further behind, than the rest of the world. The motto of the Sustainable Development Goals is, quote, leave no one behind. But the truth is today, millions are being left behind. On nearly every indicator, we see a growing gap, not just between rich and poor, but between poor, stable states and states affected by conflict and fragility. Here's an example. 60% of low and middle income countries have either met the target of reducing child deaths by 2/3 or are projected to do so by 2030. But just 30% of fragile states have met or are on track to meet that target. Similarly, nearly 40% of low and middle income countries have either met or are on track to meet the target of zero hunger, or to get more than halfway there. But not a single fragile state has met their end hunger target, and only 4 of them are on track to meet the goal by 2030. The second challenge is that this is not just a minor issue affecting a handful of unlucky countries. Overall, 135 million people are in need of humanitarian aid today, and the future of global poverty looks much more like Yemen or northeast Nigeria than it does like India. By 2030, 85% of the world's extremely poor will live in fragile and conflict states. And third, this problem is getting worse, not better. Annually, the number of conflicts we see around the world at any given moment is 65% higher today than a decade ago. Many of these conflicts are civil wars, which tend to last longer than interstate conflict. And one of the most critical areas where fragile states are falling behind stable states is on child survival. Today, 1 in 13 children live in a high-intensity conflict zone, a 75% increase on the 1990s. And if you look at the demographic trends, most of the world's children are being born in sub-Saharan Africa, the Middle East, and South Asia, some of the world's most conflict-ridden areas. By 2030, it's estimated that 70% of under 5 deaths, 2.4 million children per year, are projected to occur in fragile and conflict-affected states. We, all of us, have a responsibility to address that. And when you look at the reason children are dying, the bombs and the guns are actually only a small piece of the story. Children born in these environments are particularly at risk of death from infectious diseases like pneumonia and are highly vulnerable to becoming malnourished. In fact, and this is my focus today, nearly 50% of child deaths are driven by malnutrition. Every 10 minutes in Yemen, a child under the age of 5 dies from preventable causes. And I emphasize preventable, as I saw on my visit to Sana'a, to Bajil near Hodeidah, and to Aden earlier this year in September. The single largest driver of child death is malnutrition. So if we want to end early child mortality, especially in fragile contexts, we need to tackle acute malnutrition. And today, we are failing to do so. That's why we've invested in an innovative new approach to tackling acute malnutrition, and why I want to explain it to you today. As you must know, acute malnutrition is a condition that occurs when children are low weight for their height or lose their muscle mass. It takes 2 forms, severe and moderate, but the underlying health challenge is the same. For children, being malnourished can be a death sentence. For the severely malnourished, their risk of death increases nearly 10-fold. And even for the children who manage to survive, their lives are forever shaped by the damage caused at an early age by malnutrition. So this isn't just about the health and safety of children today, it's a long-term problem. But here's what shocks me. Global acute malnutrition rates aren't just dire, they have been largely stagnant, which highlights how little success the world has had in addressing this scourge. In 2017, 51 million children suffered from acute malnutrition, driven in part by a record 4 countries facing famine-like conditions. The burden is most acute in fragile states. 18 of them have acute malnutrition rates above the public health emergency threshold of 10%. In places like South Sudan, Somalia, Yemen, acute malnutrition is over 15%. This is obviously not just an issue of poverty or global food supply. It's a political problem as much as a health problem, and that's why it is so prevalent in conflict settings. In Yemen, where I was, conflict has created a perfect storm. According to the WHO, 1.8 million children under the age of 5 are acutely malnourished, including 500,000 suffering from severe acute malnutrition. This continued high rate of acute malnutrition in conflict is all the more unacceptable because we actually have an incredibly effective treatment if we can reach the children. Ready-to-use foods, such as the brand Plumpy Nut, can take a child from death's door to near certain survival in just 4 to 6 weeks. Yet here is the shocking fact. Between 80 and 90% of all children with acute malnutrition around the world have no access to treatment at all. If 8 or 9 out of 10 airplanes failed to land here at Hamad International Airport, it would be a public scandal. Our failure to tackle child malnutrition should be a scandal too. So why is the solution not being embraced? There are three problems that we need to address. First, an artificially fragmented approach to treatment, which separates severe acute malnutrition from moderate acute malnutrition and its treatment. Secondly, a system which depends on bringing patients to treatment rather than vice versa, bringing the treatment to the patients. And third, a lack of investment in nutrition. According to the World Bank, meeting the World Health Assembly target, which was mentioned earlier, for acute malnutrition in lower middle-income countries would require treating an additional 91 million severely acutely malnourished children in the next 10 years. It would prevent 860,000 deaths in children under the age of 5 over the course of a decade. 49% of those children live in sub-Saharan Africa. I want to go through the three problems, but more important, the three solutions. The first problem is that under the current standard operating procedure, we are prevented from identifying and supporting children who need treatment in an efficient and effective manner. The difference between a child with severe acute malnutrition and moderate acute malnutrition can be small. But once classified into severe and moderate groups, these children are enrolled in separate programs with different products supported by different agencies. Severely acutely malnourished children receive treatment in clinics with ready-to-use therapeutic food, which is provided with support from UNICEF, while moderate acute malnutrition patients are treated at health facilities with ready-to-use supplementary food, fortified flours, provided by the World Food Programme. So two different UN agencies are using two different procurement systems to deliver two different treatments for essentially the same illness. This fragmented approach results in costly systems in which children rarely get the full benefit of treatment because severe and acute malnutrition therapies are rarely both available in the same place. Here's our solution. We have developed and tested a combined, simplified malnutrition treatment protocol that will allow for the treatment of all children with acute malnutrition, moderate or severe. This approach is genuinely revolutionary and would allow children to be treated using a single program and one therapeutic product. Under a combined protocol approach, a child will be assessed, and in the event of severe or moderate acute malnutrition, will be treated until full recovery. It's simpler and more effective than the current fragmented system. It would allow global actors like UNICEF and the World Food Programme, with whom we're in close touch, to work together on delivering care in a way that saves costs, removes logistical barriers, and ensure more children get access to treatment. Luckily, the WHO, the World Health Organization, already recognizes the importance of reducing duplication and inefficiencies in its work, and we welcome the Global Action Plan's reform efforts. We believe that the treatment of acute malnutrition must be placed at the heart of this reform agenda. The second problem is different. The current model of care requires parents to take sick children to a health facility for treatment. That is an impossible task in many of the environments in which we work. Sometimes there's a complete breakdown of the health system, as in Yemen. Sometimes health facilities are targeted for attack, as Professor Lord Darzi said. All too frequently, health facilities are too few and far between to begin with. Compare that approach, where patients have to be taken to health facilities, to how the global community has so successfully used community health workers to treat diseases like pneumonia or malaria. In Ethiopia, for example, the government has invested in a nationwide community health worker program that places trained workers at health posts across the country, which has helped reduce child mortality by 2/3. So the second step in fixing the global malnutrition crisis is getting treatment out of health facilities and into communities and homes that need it. We have piloted a set of tools and training curriculum that will allow community health workers to treat children with acute malnutrition where they are. The tools and training enable low-literate community health workers to provide this treatment directly to children in need. No need for highly trained doctors from the cities or for foreign humanitarian aid workers. Our tools are cheap, intuitive, and intentionally low-tech. A simple colored band to measure the upper arm circumference that anyone can use, and simple non-numerical dosing scales that allow those community health workers to provide the required quantity. Now, we are an outcome-oriented and evidence-based NGO. And I wouldn't come to you today if I wasn't confident that this program worked. So we launched a test in one of the hardest places to work, a rural district in South Sudan, the country with the highest level of acute malnutrition in the world. We found that community health workers were able to successfully treat not 9% of children, but 90% of children with severe acute malnutrition, using the two simple tools that I have described. These results far exceed the global standard for acute malnutrition and were even better treatment than within health facilities. The third problem is there is a massive failure properly to invest in treating acute malnutrition, particularly in fragile and a conflict context, where multilateral financing has played a major role in reducing child mortality from TB or malaria. There isn't yet the dedicated specialized fund to tackle malnutrition. That kind of fit-for-purpose multilateral financing is vital to tackle child mortality as a result of malnutrition. According to the World Bank, by 2025, it will take $9.1 billion in new financing. This means that if we want international health goals to be met for reducing acute malnutrition, we need to spend nearly $1 billion a year more than we are currently spending. But critically, we need to spend it in a far more effective and efficient way. We need current donors to expand their commitments, and we need foundations, private sector companies, and donor nations who are not currently investing to expand their support. Now, by giving this neglected health issue the attention and resources it needs, we think we can improve the health outcomes of 50 million children suffering from acute malnutrition every year and save the lives of nearly 1 million children over the next decade. I'm here today not just to explain the results of our work. I'm here to appeal to each and every one of you to join the coalition to deliver those 1 million lives saved. We obviously can't do it alone. First, we need the government and political leaders in this room to have the commitment and courage to say that they will not leave fragile states behind. The Sustainable Development Goals cannot be a rhetorical commitment, but instead a real call to action. Second, we need the international actors here today, from the UN system, from UNICEF and the World Food Programme, to begin the process of adopting the combined protocol and the delivery mechanism through community health workers. I've had productive meetings with the leaderships of those organizations, and we look forward to following through. Additionally, we need the World Health Organization leadership to support countries in the development of treatment guidelines. We urge UNICEF and the World Food Programme publicly to declare their support for a common approach for treatment of acute malnutrition using a single product and a single delivery mechanism. Third, we need ministries of health in countries with high rates of acute malnutrition, particularly in the Sahel and in Central and Eastern Africa, to support additional operational research on the combined protocol delivered through community health workers. Fourth, we need the donors and business leaders in this room to provide financing that is fit for purpose. Innovative thinking enabled the creation of multilateral funding institutions like Gavi, and the results have been transformative for the health of people in low-income countries. We need the same to tackle the scourge of malnutrition. Donor governments and philanthropies have provided the backbone of financing that has allowed these international institutions to deliver progress, and we need the same care and attention for these children now. If we can get these four things from you, political commitment to fragile states, a unified approach in the UN system, Ministry of Health commitment, and fit-for-purpose financing, we believe we can drive the next dramatic reductions in child mortality globally. We think we can go from 10% rates of treatment to 90%, and in the process reduce acute malnutrition rates to under 5%, meeting the World Health Assembly target for acute malnutrition by 2025. So, one world, one health, as this conference says, one protocol for severe and acute malnutrition. I'm not promising to you it will be easy, but I am promising you it is possible to save these children. With 1 in 13 children around the world living in a war zone, what other choice do we have than to fight for them? Thank you very much indeed.